Ma'am, we are live now.
Yes, thank you. So good evening, doctors, and thank you very much for joining today's yet another exciting webinar. Thank you, Dr. Ved Prakash, sir. Thank you for giving us time and accepting our invitation. I'm sharing my screen now. So I'm very honored and privileged to introduce Dr. Ved Prakash, sir. Sir is Lab Director of Southern Fertility and IVF Center, Delhi. Sir is trained in IVF and ICSI from Andrology and IVF Lab, KK Women's and Children's Hospital, Singapore. Sir also received training in IVF and ICSI and embryo biopsy from AZVU, Brussels, Belgium. Sir is Vice President, Academy of Clinical Embryologists of India, founder of International Human Embryology Research Academy, faculty of Fellowship in ART, Amity University, Noida, and also visiting faculty, MSc in ART, Mysore University. Sir's area of interest are in vivo fertilization to blastocyst formation and innovation in embryo culture system. With this, may I request and invite Sir for his talk on advanced techniques in ART for male infertility. So thank you, sir, and over to you.
Thank you. Thank you, Dr. Prachi. Thank you so much. First of all, thanks to Shield Connect for inviting me for a wonderful webinar. So today we are going to talk about advanced techniques in ART related to male infertility. As you all know, that male infertility's contribution in infertility is around 40%, and 40% female and 20% mix of both. So most of the time we think about female is having problem, and we talk about IVF and different techniques of IVF. But of course, now there is so many things are coming up, advanced techniques are coming up for infertility, male infertility also. So today we will discuss only about male infertility topic. So I will start with sperm because male infertility is something related to sperm only. So whenever we talk about male infertility, our focus remains to on sperm. So what is the impact of sperm in embryo development? So in embryo development, from 0 to day 5, all the in vivo environment is like that. First, sperm has to enter inside the uterus and activate oocyte. After that, there are so many other factors which related to sperm, and which there is contribution of sperm in the embryo development. So why sperm cells are so interesting? Almost always in excess, not a limiting factor. So genetic uniqueness in each sperm provide a wide variety of phenotypes, and during in vivo, we do not know how one sperm is selected and on what basis. So sperm passage in nature versus different assisted reproductive treatment options. There are so many key events for sperm. It has to start from testes to epididymal sperm maturation, ejaculation, vaginal deposition, cervix and mucus passage, then uterus tubal passage, then ovum recognition and fertilization. These are the after post-fertilization, the embryo division, embryonic genome activation, implantation, fetal development, and healthy newborn. These are the natural key events for sperms. And in natural, these events should be there. But if there is some problem in sperms, or maybe in female problem, egg problem, we need to go for assisted reproduction like IUI, IVF, ICSI. And if there is no sperm, then we have to extract the sperm from testes also. So what are the sources of semen? Semen sources are, it may be fresh or frozen, and sometimes if there is a problem in ejaculation, we use electroejaculation for that. Sometimes vibration induce semen, and sometimes what happen, sperms are not coming out. It is going inside the bladder, so it is retrograde ejaculation. And sometimes there is no sperms in semen, then we have to extract the sperm from epididymis or sometimes testes. So what is the conventional insemination? First, we have to do semen analysis, initial analysis. On the basis of that, we see how the sperm is, sperm count, motility, all the factors. So what we are doing, we are using Mackler chamber or a hemocytometer to check the count. And in some cases, there are CASA is also available, the computer assisted semen analysis. On the basis of that, we are checking the sperm count, motility, and progression. So post-processing semen analysis determine insemination type. What kind of insemination we have to do? Maybe conventional, or maybe sometime we have to do some advanced technique. We have to use some advanced technique. So in semen, what we are checking mainly count, motility, and morphology. These are the main things which are based to select the sperm, and as well as type of treatment we are going to provide the patient, like IUI, IVF, or ICSI. So in conventional insemination, we need around 2.5 to 5 million motile sperm in concentration and minimum of 40% motility. So this can be achieved by doing some simple technique like swim up and density graded separation. So most sample exhibit a minimum of 80% motility. So these can be used in we mostly use lower concentration 2.5 million for normospermic, but when sperm count is very less, then we use higher concentration 5 million for oligospermic samples. So what is the goal of sperm preparation procedure? We have to remove sperm from inhibitory effects of the semen plasma and obtain sufficient and morphologically normal sperm for insemination or retrieved oocyte. So what is the ideal sperm preparation? It should be quick and cost effective. Isolate the highest number of motile, viable, or normal sperm, and sperm do not need to be motile for IVF. So remove dead cells, leukocyte, bacteria, and contaminants that would be toxic to oocytes. Allow processing of high volume ejaculates and fresh or frozen semen specimen. What are the benefits of sperm isolation technique? It removes all or minimize bacteria, viruses, antibodies, dead cell, leukocytes, and it extends shelf life of sperm and promote capacitation by removal of seminal fluid component like prostaglandins and ROS and capacitation inhibitors. Its ability to resuspend sperm in a small volume and concentration appropriate for final use. So in vitro sperm selection. So what we are doing, first semen examination, morphological assessment, sperm preparation method, sperm function test, sperm selection in viscous media, and advanced method of sperm selection. These are the method of sperm selection. In semen examination, hallmark for fertility evaluation is in male, provide more detailed information on routine basis. If abnormalities in sperm production or function alone or in combination with other factor account for 30 to 50% of all cases of infertility outcome. What we are doing in semen examination, macroscopic parameter we are checking like volume, appearance, color, liquefaction, viscosity, pH. In microscopic parameters, sperm concentration, sperm motility, morphology, leukocyte concentration, and agglutination. So in sperm morphology, in In the 80s, pioneer studies on sperm morphology, Tigerberg and Kruger, USA, correlated the architecture of spermatozoa with IVF outcome and suggesting importance and predictive value of sperm morphology for fertilization and pregnancy outcome in treatment by Perrinot et al. In 1993. And there are several ways to analyze sperm morphology. All morphological measurement to be made using fixed stain smear like Pepinacul or deep quick or sore staining. So most of the IVF lab now using deep quick. It give result in very fast. Maybe in half an hour you will get the report of sperm morphology. These are the Kruger strict criteria. This is the normal sperm structure, and these are the abnormal sperm structure. So influence of individual sperm morphology on fertilization, embryo morphology, and pregnancy outcome of intracytoplasmic injections are like this. In normal sperm morphology, fertilization rate is 72.5, but in abnormal sperm morphology, the fertilization rate is 64.4. You can check here, and as well as in pregnancy rate, you can see how the difference is there. So these are very significant difference in morphology and IVF normal analysis. Semen preparation. How we do semen preparation? Semen composed of mixture of secretion, other cells, and many anti-capacitating factors. There are risk of oxidative and osmotic damage in vitro, and it is needed to separate best motile and morphologically normal sperm. So classical sperm for preparation method are based on motility and count. These are the method like migration, swim up, and density gradient. So there are some other things are also there. Sometimes the sperms are not motile, they are not moving, but still they are live. So how to check this? So we have to check sperm function test for that, like hyposmotic swelling test is there. It is based on the principle that viable spermatozoa have intact membrane. What characteristics are like swelling of the cytoplasmic space and curling of the sperm tail, like you can see here. And normal test result are more than 58% curling tail is considered normal. Test may be used to add selection of viable spermatozoa for use in ICSI, especially in those cases of severe asthenospermia. In some cases, the DNA fragmentation are also we are checking. Sometimes there are multiple abortion is happening and missed abortion are going on. If sometime quality of embryo is not good, so in these cases one should check DNA fragmentation also, because DNA, it is important cause of reduced fertility potential, and it is useful marker for sperm function. Recently, WHO also added this test in routine test. You can use, we can use this test if there is failure. Not in routine, but of course, if there are some failure cases, you can use this DNA fragmentation also. So, what sperm motion? Now we will talk about the motility also. Not easy to select sperm according to morphologically characteristic while they are in motion under culture media, because sometimes they are moving very fast in culture media. But we need to have some medium or something that when we can easily pick up the sperm. So what we are using, that viscous medium, that this sclerate spermatozoa allow evolution in its three-dimensional motion pattern, permitting morphological assessment. And at that time, you can use PVP like media in that case to pick up these sperm. What is retrograde ejaculation? In retrograde ejaculation, as I told you, that sometime ejaculation is happened, but their semen is not coming out. So it is going backward in bladder. So we recover the sperm from after when patient tell us about that ejaculation is happened, we ask him to give urine, and we collect the urine in medium and centrifuge it, and we take out the pellet and use check the pellet if sperms are there or not, and if sperms are present, we use that sample. It is very it is start like that. First you have to neutralize or give the patient to some kind of oral bicarbonate, and in some cases we can even install buffer in bladder also, and ask him to go for collect the urine in container, and that container we take in lab and centrifuge and form the pellet, and from pellet we can collect the sperms. There are some cases when sperms semen is coming, but there is no sperm. In these cases, we try to take sperm surgically, like from epididymal sperm we can take, and sometime if there is no sperm in epididymis, then we even go to biopsy, testicular biopsy also. So there are different method of preparation of testicular and epididymal sperm. In epididymal sperm, they usually show some movement, and it depend on concentration. We use simple wash, seam up, or some motility enhancement method also. If they are very slow moving, or even they are not motile, they are not moving. In testicular sperm, usually they are not motile, and simple wash is preferred, and we generally incubate it overnight under oil. So first examine for presence of sperm in the operating room. Meticulous laboratory search for mechanically processed testicular tissue, possibly to include enzymatic treatment like collagenase. In chance of finding sperm after chemical digestion, when sperm were not initially found in 25 to 30%. So sometime we are also using collagenase, that digestive enzyme, to get these sperms. Other study reports a success rate of 7% mechanical preparation, followed by multi-hour, many technician search in the laboratory. So how we select the sperm in advanced techniques are there. So sperm selection we are using with the help of these, like motility stimulating agent, pentoxifylline, theophylline, and caffeine. Now most of the center are using theophylline because it is ready to use medium available. So most of the labs are using theophylline. And if theophylline is not, then we even use hypoosmotic swelling test. On the basis of that, we can select the sperm. And one more, if sperms are mature or not. So again, we have selection method of hyaluronone binding selection. And in motile sperm, if morphology is very bad, then we can use even IMSI system and MSOM system. Motility stimulating agents are pentoxifylline and theophylline. They basically methyl xanthine derivatives. Most commonly used method for motility enhancement in both fresh and frozen thawed sperm, and 3 to 4 mm are used for 30 minutes, and after 30 minutes you can see sperms will start moving, and easily you can pick up the sperm. So most of the things like caffeine and platelet activating factors are not so many people are using. These are only research based. In hypoosmotic swelling test, as I told you, we use that medium solution test, hypoosmotic solution, and viable sperm will swell and tail will curl. And when you see the tail is curled 50%, then you can choose that sperm that shows that membrane is intact, and you can use that sperm for ICSI. In IMSI, it is basically Barto et al. Introduced ICSI using high power differential interface contrast optics, allowing visualization of sperm at ultra high magnification and in real time. This fine morphological integrity of human sperm nuclei is positively associated with fertilization and pregnancy rates. The strict descriptive criteria for normally shaped nuclei. So here in second slide, you can see sperm's size is very big and easily you can see the abnormality. Like you can see over here, small vacuoles are there. So multiple vacuoles are not good to use for ICSI. Only one small vacuole is we can use for ICSI. And without vacuole is very good if it is there. So criteria for morphologically normal nucleus is smooth, symmetric and oval shape. Nucleus should be homogeneous, no extrusion, no invaginations. Maximum of one vacuole, less than 4% of the nuclear area can be used for ICSI. These are the normal and these are the abnormal sperms. Next. So these are the significant finding for IMSI versus ICSI. You can see significantly higher implantation and pregnancy, significantly lower miscarriage rate in IMSI group. In 2010, again, Fergary et al. Significantly lower aneuploidy rate in IMSI group. And again, in 2010, 64.8% of sperm selected in ICSI had significant DNA fragmentation, embryo quality, pregnancy and implantation rate higher in IMSI group. And Monket et al. In 2010, again, swim up, they showed that swim up sperm have less nuclear vacuolation than density gradient sperm. Likewise, there are so many studies which shows that IMSIs are better than ICSI in case of morphology are very bad. Again, there is one more report in 2010, intracytoplasmic sperm injection outcome versus IMSI, intracytoplasmic morphologically selective sperm injection outcome. They showed that the current meta-analysis can conclude that IMSI not only significantly improve the percentage of top quality embryos, implantation and pregnancy rate, but also significantly reduce miscarriage rate as compared with ICSI. So next is sperm hyaluronate binding assay. This method is showing ability of mature normal sperm with intact acrosome to bind to hyaluronic acid, the main mucopolysaccharide of the cumulus. So hyaluronic acid does not bind to immature sperm. If sperm is mature, then definitely it will bind to hyaluronic acid. So on the basis of that, we can select sperm which bind this acid. So it is commercially available kit for testing and use. Pixie plates are used for journal routine ICSI, and hyaluron binding assay is the test kit which is available to check if sperms are mature or not. It is rapid test and simple. The correlation with sperm maturity, strict morphology, chromosomal integrity, progressive motility, hemizona assay is rapid test which can give us a report instantly. This is the physiological ICSI. In this process of fertilization, the sperm bind to hyaluronic acid present in the cumulus oophoris by HSPA2 protein with hyaluronidase activity that induce acrosome reaction. The Pixie device, a dish similar to ICSI dish, contain microdots of hyaluronate hydrogel which need to be hydrated by media before ICSI, and selectively binding of sperm to the culture dish shows more viability, non-DNA fragmented and with lower rate of aneuploidies. So here you can see sperms are sticking to the border. Here. These moving sperms are not good. They are not mature. And this one, this stick to that's petri dish. This is mature one. They are not moving. Sperms which are not moving, they are stick to the petri dish. They are mature one. This is how we select in pixie dish. Pixie versus ICSI, it shows statistically significant improvement in clinical outcome in 240 in vitro fertilization patients. And it significantly reduced level of fragmentation, increased CPR, clinical pregnancy rate, and decreased miscarriage rate associated with the use of pixie derived embryo. One especially for severe oligospermia and even in DNA fragmentation patients. First developed in 1993, silicone and glass microfluidic devices and gravity-driven pumping system. The microscale integrated sperm shorters, and it significantly decreased in DNA fragmentation as compared to initial semen, as well as following vast centrifuge density gradient, centrifuge and swimmer. Quartz microfluidic system is it shows highly motile sperm within 5 minutes used for ICSI. So now it is in trend. Most of the centers are using microfluidic system also. This advantage of microfluidics are it is simple to use and it is safe and reduce percentage of sperm with DNA fragmentation. And disadvantages are not capable of processing entire ejaculate. This is the main disadvantage of microfluidic. Only you can say around 1 ml, 0.1 ml sperms, ml.
Hello.
Hello.
I think we lost Sir's.
Yes, no, I think there is network issue.
Sure. So let me call. Sorry again, because of this connectivity issues, Sir logging again. So we will wait.
I'm sorry,
Hello?
connection
No,
was
no
lost.
issues. No issues, sir.
Sorry, my connection was lost. So again, there is one more technique is max is also there, but it is also not so many people are using this technique. It act like damage sperm binds to NX5 and are retained in magnetic field.
Sir, sorry to disturb you, sir. We want to see your slides. Slides are not visible.
Oh, sorry. I have to share it again. I was
Yes,
thinking
yes,
that it
yes,
is.
yes.
Let me see. Where is that? Yes.
Yes,
Fact-
sir. We can see now. Yes, sir.
So next is just a minute, please. I have to do this. So next is magnetic activated cell shorting technique. It act like damaged sperm binds to NXN5 and are retained in magnetic field. These techniques are not very frequent, not familiar. People are not familiar to this technique and not so common. People are using these techniques. It is also showing very good result in fertilization, and cleavage rate are also good, as well as pregnancy rates also showing good result according to Derken et al. In 2007. There are few more techniques like Raman microscopy. It can identify different level of oxidative sperm DNA damage, non-invasive, non-destructive, isolated cells with intact DNA, relatively easy, reproducible and accurate, but it is very expensive equipment, not validated. It is still experimental, and there is no threshold value till date. This. And one more technique is sperm membrane surface charge. It is based on the negative electric charge of the plasma membrane due to the expression of GP20/CD52 added during the passage through the epididymis. The level of expression of CD52 protein appear to be positively correlated with morphologically normal, capacitated, and with reduced DNA fragmented spermatozoa. These all techniques are routinely we are not using this technique. They are still in research. So let's see in future, maybe they will come with good affordable instruments will be there, and we will use in routine practice also. So advanced sperm selection techniques are hypothesized to improve ART outcome through the selection of sperm with a variety of beneficial characteristics. Although individual small studies have suggested that these techniques have clinical benefit, there remain less comprehensive review of randomized controlled trials. The current review needs more studies to be included so the results can better guide clinical practice and further applications. The gold standard of sperm function remains the ability to fertilize and oocyte in vitro. Abnormal shaped sperm have an increased chance of poor outcomes. Proper semen examination, sperm preparation, and wise sperm selection technique recommended in ART. The onus for sperm selection shifted from count, motility to other parameters. So I will end my talk with saying the key to everything is patience. You get the chicken by hatching the egg, not by smashing it. Thank you all. Thank you so much.
Thank you, sir. Thank you very much for that excellent presentation. So especially that video of the where the mature sperms are selected. So that was amazing. Very excellent video was there. So few questions, sir.
Yeah.
So there are many techniques are available, like Marx-based technique, then hyaluronic acid-based technique is there for sperm selection. Then microfluidic technique is there. So are all these techniques are used in the lab, or are there specific conditions, or how is it decided, like which technique to be followed?
So as I told you in starting that three main parameters are there in this. Main count, sperm morphology, and motility.
Right,
We
sir.
have to think about whenever we decide the technique, which technique we have to use. We have to think about the is it count is less, then obviously ICSI, simple ICSI can do our work easy. There is no issue. If motility is less, but motile sperm you can find easily in that sample, then of course ICSI can be done. Okay, but up sperm are not viable, not moving. They are not moving, but they are viable. But how do you know? Then you have to have some kind of test and some activating agent, so we can select the sperm, viable sperm. Like I told you, hypoosmotic test, you can use that solution to choosing the viable sperm. Or second, now there is ready-made solution is available. So like theophylline, pentoxyphylline, and they can be used in that case. If sperms are not live, just put 2 microliter to 3 microliter drop and near the sperms. Sperm, if they are live, they will start moving.
Okay.
Okay. So at that time, yeah, you can use that sperm for ICSI. This is the thing. And if morphology is very bad, so definitely IMSI can help us, because in IMSI, what we are doing, we are that image of that sperm magnification will be around 6,000 more. So a big image will be there, and you can select a morphology, best morphology. If there is no vacuole or vacuole is there, on the basis of morphology, you can select sperm. And like Pixie, as I showed that video, Pixie is basically when you know that sperm's DNA fragmentations are very high, and even the sperm their maturation is very less. You are saying the sperms are not quite mature. Or how do you select the sperm? So that sperm will bind to the petri dish, that which is covered with the hyaluronan binding acid on the petri dish. Though that time sperm will stick to that acid and it will not move. If sperm is mature or DNA fragmentation is less, then it will bind to that acid. Then you can pick up that sperm and you can use that sperm. So these are not routine. So what I mean to say that there are techniques available which can help male infertility patients. Sometimes there is no sperm seen in semen, so definitely you can extract the sperm from testes, or even in there are agiospermia, like 2 type of agiospermia. It is non-obstructive and obstructive. In obstructive agiospermia, you can easily find out sperm just by FNAC or maybe biopsy you can do. But in non-obstructive, it is very difficult to find these sperms. In that cases, you can go for even micro TC. So micro TC can help you in that case, and you can get sperm. There are possibility to get sperm in 10 to 20% of patient in that micro TC. So there are techniques which can help to overcome these problems of male infertility. Advanced techniques are even there.
Right.
So these techniques are not routinely we are using, but definitely on patient selection, we have to check the patients has in last cycle, what is the result of that cycle. So on the basis of that, you can select the techniques.
Right, sir. So based on semen analysis, whatever the problem is there, accordingly, yes.
Yeah, in male infertility, you know that male infertility, simple semen lysis can tell you so many things about that.
Right.
So first it is, but it should be in a good lab. Semen lysis should be in a good lab. So because in some labs, they are, the pathological labs are also doing semen lysis. Their reports are coming like 90% normal, 80% normal. And in our routine practice, we rarely see 20% normal.
Right, sir. Right, sir.
So this is the difference.
Right, sir. So not any lab, but specifically.
Yeah, IVF lab. I think I will go for IVF lab only. It is better if we are going to take treatment for infertility. So IVF lab is best for these things.
Right, sir. So do you recommend sperm fragmentation testing for all the semen samples?
Yeah, not for all the patient, but definitely in those patients, if there is poor embryogenesis and multiple failure,
Yes.
missed abortion is happening regular, 2-3 cases have happened. So definitely, and in that history of smoking kind of things, alcohol is there, so obesity problem is there. So definitely we recommend DNA fragmentation. Earlier we used to do very low number in DNA fragmentation test, but nowadays daily we are doing 2-3 cases. So you can imagine how many we are doing in a month.
Right, sir. Right, sir. Understood. So the fragmentation treatments are also available. So
fragmentation treatments are also available. That many antioxidants are present in a market, and we are also using for 3 months at least. When we saw that there are so many, there are too much DNA fragmentation in sample, so definitely patient should go under at least 3 months treatment for antioxidant like defrag and Progenex kind of things are available, and they are very good in doing this. I have very good experience, and we have done so many trial on that small trial we have done in patients. So they are very good.
So nowadays, in many conferences, there is a lot of discussion about artificial intelligence in IVF. Can you guide us something? Can you tell us something more, especially for?
So recently we are also doing this. Started doing this artificial intelligence in our lab also. We are using for blastocyst selection. Definitely it has role and it improve the success rate. In my experience, last month we did around 21 cases, and we are able to do transfer around I think around 8 or 9 patients, and all are pregnant.
Oh,
all are pregnant.
So 100% kind of success rate.
But we are not able to do a rest of the that there were patients were 21. We have done only 8 or 9. So maybe after doing the transfer, we can come to conclusion how many are pregnant. But still, yes, I can say all are pregnant in that 8 to 8 are pregnant.
So still, it is definitely helpful.
Yeah, it is. Okay. It is good. Even that in sperm selection, AI is coming. Real time, you can use that sperm and select the best sperm by using AI system.
Right, sir.
It is coming now.
Right, sir. So it is recommended. So that's a new buzzword.
Yeah, it is recommended. Yes.
Right, sir. Right, sir. So as a company, I think we should look forward for those.
Yeah, definitely. AI is the future now. So in everywhere they are going, even the success rate they are predicting by using AI. So for in ultrasound, they are using AI system. So many things, and now they are using AI, starting doing this.
Right, sir. Right, sir. So thank you very much, sir. Thank you for that amazing presentation and wonderful discussion also, sir. And thank you very much for giving time and for this webinar. So thank you, sir. Thank you.
Thank you so much. Thank you so much. Thank you.
So we will